All right, we're all caffeinated up and ready to rock, right, guys?
Absolutely.
So it's time to talk public health, right? So it's time to talk public health, and we are delighted to have some distinguished colleagues up here on the stage. I'll be facilitating, but we have folks that are from very different parts of the public health informatics story, so it'll be really interesting to get good perspectives. But just briefly to remind people what public health is. Public health is a checklist where you have to report stuff and that's it, right? No. Public health is set up to protect all of you and your loved ones from bad stuff happening. E. coli outbreak in the food and your kids suddenly doesn't have arms and legs, right? Public health is like healthcare in that it's intensely data-driven, and it's in part about finding insights in the data that help us act so that maybe 110 people don't die, maybe 12 do, right? So it's a sacred thing. It's an unsung hero, and you don't hear about it until it doesn't work. But today you're hearing about it. And there's some deep laid plans, because make no mistake about it, much of the data, the good news is, much of the data in public health comes from healthcare. And other good news, our ASTP and other friends, CMS friends, the table's been set and it's time to eat, right? It's time to plug public health into that ecosystem so that we can remember, it's about faster insight so we can act to protect the public from infectious and non-infectious risks. And so there's never been a more exciting time to automate some of the inefficiencies. You know, what I like to say is traditional public health data reporting has been it occurring to somebody in a hospital or clinic that I ought to, this is one on the list of 50 things I have to report, and then by phone call, fax, or homing pigeon, calling the public health department if they think about it. Now we have the ability to have ticklers, listeners that listen for things, and then rapidly in an automated way with no human hands contaminating, actually getting those insights just in time for AI, right? So we're going to talk about a lot of these things. I'm Jim Jirjis with the Centers for Disease Control, and I'd like each of them to introduce themselves. I said keep your introductions of yourself down to 15 minutes each, so we have time for the actual content. Now, yep. Please introduce yourselves, and then I'll begin with the questions.
Yeah, thanks, Jim. Good morning, everyone. I'm Tim Powell. I'm an epidemiologist and informatician. I work for J. Michael Consulting, which is a company that just does public health informatics and interoperability. It's a great time for this as we're working across the nation to improve. Through them, I have the distinct pleasure and honor of getting to work with Virginia Health Information, which is a organizing body for the Health Information Exchange in Virginia, where I assist with strategy and consultation to the state health department, because public health, a lot of this is really new, and it's not intuitive of how we're going to use some of these new tools and how we're going to change processes to more rapidly respond to the world around us.
Good afternoon, everyone. Is it good afternoon? Oh, it's still morning. It's afternoon for me. My name is Meigs, and I am the Managing Director of Informatics for the Association of Public Health Laboratories. And you're probably wondering, how the heck do I fit up here? Well, APHL, as a professional association that has been around since, I think it has its basis in I think it goes all the way back to like 1890 from the original AMA. But I've been with APHL for 20 plus years. I came from the Massachusetts Department of Health, and where I was a bacteriologist, and I also was the LIMS lead. When I got over to the national stage and the national level at APHL, I was working very closely with our members, right? And our members, as public health laboratorians, they are quiet, but they're tenacious, and they are smart people, but they don't like to be up here. So this is not my comfort zone right now, but I'm gonna push on through. But what happened in 2006 was that our members actually put forward a proposal and asked myself and one other person, because there were only two of us in our program at the time, to put this supplemental request into CDC to actually support harmonizing and standardizing terminology around flu. And also to figure out, how do we solve the hamburger problem? Okay, so at the public health laboratory, and I had to write it down because I forgot my glasses though.
He's over.
So the hamburger problem is like a foodborne investigation. This is a issue, right? So if it's if it comes to the public health lab for confirmation or outbreak response, if it is the ketchup, the mayo, or the lettuce, the data has to go to FDA. If it is the meat, it has to go to USDA. If somebody gets sick, right, if it's an actual patient involvement along with food, then we have to go to CDC. But not just CDC for the lab confirmation, but we also need to send the data to the biological laboratory, right, in case there's an issue with the response. If there's a problem with the hamburger that is related to the lettuce and the fact that a fertilizer or there's a chemical involved, it has to go to another section of CDC, which is the CDC LRN lab on the chemical side. And if there was an animal stock involved, which we've seen very recently, then it has to go to the, I think it's like the National Animal Health Laboratory for further testing. So they came to us and said, please solve this. And we ended up developing this really simple route not read hub, right? It just said, send me your data and we'll send it to whoever you want. That's all we were doing. And we supported our members. Well, that expanded and moved into what is now known as the APHL Informatics Messaging Services. So huge mission drift for APHL. However, we are, as a nonprofit organization, we are committed to public health writ large. It just so happens that our little informatics program went from 2 people and $100,000 to 30 people now and a national infrastructure. And so I'm here not just representing APHL, but I'm here representing my partner organizations like CSTE and others, as well as our stilts who are here in the audience today. So I hope I do them proud, and I'm excited to talk.
Excellent.
Great. And I'm Craig Behm. I'm the CEO of CRISP Shared Services. We provide nonprofit interoperability support for 8 states and territories. I should have been taking notes when Jim said what public health was. But maybe importantly, we're also an implementation center through the CDC program to help modernize public health. So we're really eager to talk about the intersection between our day jobs and now our public health friends.
Thank you. Well, when Michelle was talking about the hamburger and the lettuce, I got hungry until she started talking about E. coli, and then I lost my appetite. But so as you can see, we have sort of the boots on the ground experience. We have experience with the intermediaries in this whole ecosystem, and experience with the successful HIE and implementation center that we'll talk about in a minute. So I wanted to kind of walk through from those different perches, give you a taste at the boots on the ground to each level of kind of what some of the wins and challenges are. How's that sound? Good, because that's what we've got. Tim, boots on the ground. Tell us some of the wins, challenges. We hear TEFCA, we hear public health use case. What are your experiences when the rubber hits the road with should this be done next Tuesday? Or is it a little harder than that?
Yeah, that's a great question, Jim. And let's create some context. So a little over 20 years ago, I was an epidemiologist in a local health department. And my job was to respond to reports of notifiable diseases. And those reports would show up either via fax, US Postal Service, or if it was something really urgent, like it had a star on the list that was a rapidly reportable, or that the person at the practice or the hospital said, I don't know what this is and I'm concerned, then you'd get a phone call. That was the only form of really electronic, real-time communication that we had, was a phone call. And at that time, you take the report and literally write it down on a paper log sheet and fill out a case investigation form and mail that in, and it would then get it entered into a DOS system and sent to CDC. And that's how we counted. I mean, I refer to that as the counting beans phase of things. We weren't doing anything other than saying there's X number of cases of this thing. At that local level, though, the action beyond filling that form out was, in turn, picking up the phone and dialing your either primary care physician who reported it or the IP at the hospital and going, I have questions. And in turn, typically the response was, you can either come up and pick up the big stack of paper that we're going to give you, which is the entire medical record for this patient, or we'll fax it over to you, which is another 7,500 pages just coming through. That was over 20 years ago. A lot's happened in this window. I've observed where we went from everything being manual, everything being reasonably painful and slow, to electronic lab reports. That was game-changing, and thanks to our dear, dear friends at APHL for helping facilitate all of this, where today, 98.9%, I think, of the jurisdiction that I worked in, at least, that they're all electronic, and this has made life incredibly better from the ability to respond rapidly, to make informed decisions. Unfortunately, the same challenge exists of that, gosh, I've got this thing. What else happened in this person's life that's going to be relevant in order for us to classify it as a case of disease? Because this is really a distinct difference here, is that a clinician can diagnose a patient. In public health, we're a little different. We like to make sure that it meets a case definition so that we can count that bean effectively. And so you pick up the phone in probably 50% of the instances still and dial up the infection preventionist or the provider and say, I have some questions. And in a good chunk of the time, the same outcome occurs. Let me fax this across to you. So we're able to respond quicker. We have, in many instances, particularly as we think about the electronic case reporting that we're receiving, there's been a huge effort really since late 20, of many of your institutions getting on board, submitting EICRs to public health, which are great. It's helping accelerate our ability to respond.
Tim, what's an EICR for the crowd?
That's a great question. I apologize. That's the Electronic Initial Case Report, which is an electronic version of essentially that piece of paper that we would have gotten from a provider previously that says, here's some patient names, some basic demographics, the condition that we believe we've diagnosed them with, and possibly some labs if it's there, other relevant information as available.
So Tim, now that we have ESR and labs, so there's no more phone calls, faxes, et cetera?
No.
Is that what you're saying?
No, unfortunately that is not the case. So with each of these, those are initial. They give you just enough flavor to go, oh, we think that this person may, and so literally the same action is occurring. I'm going to pick up the phone. I'm going to say in 50%. This is just a wild guess at this point. Fortunately, a lot of the local health departments have made sound and solid relationships with the healthcare organizations in their communities and have been granted access to their electronic health record system. So they're able to log directly into there, search for the patient, break the glass as necessary to be able to see that information, and capture that for the purposes of their investigation and classification of that disease, and in certain instances make recommendations about the treatment of that patient. But this is still in 50% of the time we're saying, can you fax it over to us? Which is really, it's a burden on the healthcare organizations to do that work. It's a burden on public health to sift through these voluminous documents that we're receiving to find the key details. But we're at the gateway right now of change.
Sounds very, there's a lot of reason for optimism, still in transition. I feel really old. How many of you remember a time when fax was like pretty advanced technology?
Yeah.
2 of you, okay, I am old. So let's move to the national setting. Michelle, tell us a little about your take on what's happening in public health from a national infrastructure perspective. I know you're representing several groups up here.
Sure, absolutely. Thank you, Tim, because he gave me a nice bridge here. A lot of you have been talking about participating in electronic case reporting. I'm here to remind everybody that ECR is extremely important, and pushing that forward at a national level is going to make a difference, a huge difference. However, we completely recognize that we need to mature how we do that and how we work with healthcare from an infrastructure standpoint. But I'm also here to remind you that, remember that ECR was a proof of concept in 2019. And in 2020, it went full production, no holds barred because of COVID. And so we as a community, CDC, others included, we have not had a chance to stop, think, and kind of reassess how this is moving, because how do you stop a moving train? right? And so right now what we are trying to do is to say we have to step back just a second, right? And say, where are all the resources we have? Where are all the people? Where's all the expertise? And how do we strategically place them so that we can reduce burden short-term and long-term? Because there's a lot more to do than just case reporting. I also want to stress the fact that public health has a business problem, right? And the business problem is that informatics is never an operational component of public health. It's always funded through a special project or a special initiative or through little categorical funding. So I talk about AIMS and running the AIMS platform as a public health intermediary. That public health intermediary right now is funded by 55 little tiny budgets. So influenza pays part of their AWS bill, vaccine preventable disease does theirs. So the CDC programs right now are also having to change the way that they allocate their resources. And I have to give a huge shout out to the OPHDST team or the data team at CDC because they've been supportive of this, and they're right there alongside public health trying to get the programs to really understand how to let go of pieces of this so that we can centralize it and we can make things easier. So we are there, and I guess I would just ask our healthcare providers, like, we are here. We want to learn from you because we are really just starting our journey, right? From a business standpoint, it wasn't. I've been doing informatics work since the anthrax letters, right? When I was in the lab, when I sat there and I had to test every freezer burnt turkey, every piece of salt that came into an envelope, because my governor had said, we cannot put no extraneous material observed. So we had thousands upon thousands. And I had all this specialized training, BSL-4. I didn't have a computer system. We had to just write it all in a logbook. And that's when I was like, this is ridiculous. This is so dumb. So fast forward, we have had to build public health infrastructure $100,000, $200,000, $300,000 at a time. And so at this point, I see this as a business problem. The technology, yes, it needs to advance. We need to move things in a different direction, but we need to think broader in public health. And I'll tell you, when I was in a meeting in San Francisco with Jim and others, if anybody knows me, they know I carry around this stupid book everywhere I go. It has all of my silly diagrams and things that I want to try and drive people crazy about. I left it on a table, and somebody wrote a note in it that just said, public health must change or die. I don't know who wrote it. I have some thoughts, maybe somebody in this room, but it just says public health must change or die.
I think Elon Musk, I saw Elon Musk slip in.
There was a must, not a shall. They must. So I think we're all on that same thing, and we're ready to go.
Well, thank you very much. Christmas ideas for Michelle. Get her an electronic organizer.
No.
Craig, you bring an interesting perspective, a couple hats here. One is the wildly successful CRISP HIE that I think public health has enjoyed being able to use the portal, for example, there. But also you have a hat with the new implementation centers, funding from CDC, 2 partners, you're one of them, 3 implementation centers, to actually help the different state, when you hear jurisdiction or still, think state, local, territory, tribe, where they have limited staff, et cetera, how to modernize them. So your organization's also one of the 3 selected. So from those 2 perspectives, what are your thoughts as you observe public health, the opportunity, et cetera?
Yeah, maybe we should start with the obvious. Like, interoperability is hard. Obviously, you all know that. But I would argue it's hard not necessarily because of technology. It's hard because of people, right? To borrow a line from you, Jim, we're moving much more data. I'm not convinced we're moving more information. Right? Even in a place like Maryland, where we have very broad connectivity, in Connecticut through Connie, in DC through CRISP DC, hundreds of thousands of transactions, FHIR, APIs, CDS hooks, all the things. And every single day I get a call. Why wasn't that image there? It was, doctor didn't check it. Well, how come I didn't get the alert on the overdose? You did, you click pass, right? So there's a lot of just like boots on the ground nuance to drive the usability of all the information we're trying to put out there. That's on the normal healthcare side. On the public health side, and public health people tend to be very polite, they don't care about TEFCA, APIs, FHIR, interoperability, or any of this. They do not care because they're too busy dealing with lead in the water and lead in the walls, and they have veterinarians on staff, and they have lots of paper going back and forth. So there's just a lot going on. They already have the impossible task of being under-resourced to do this critical work. And we're really eager to get into the weeds on their language, on their priorities, to figure out not just how do you move the data, but how do you make sure that the epi who's already busy trying to deal with air quality can really identify the asthma kids to enroll them in a program to get them help. Like, another CDA is not the thing they want. What they really want is the right information within their workflow, seamlessly, securely, so they can just do their jobs. Something that I think we really need to reflect on is the value proposition for this community. We were really, really proud to go live with 3 public health agencies, Fairfax County, Virginia, Maryland, and Alaska Departments of Health, to query TEFCA for public health on July 1st. They were great volunteers. They came to the table. It was a big ask because they were very busy people. Yep. They got no data, nothing returned.
From healthcare.
And now we have to go back every month and remind them, no, stay with us, stay on the journey. This is gonna be worth it. And it's a really tough sell to people who are already doing impossible jobs. And so I would just encourage all of us to really figure out, what are we asking them to do and what are they getting in return?
Excellent. So if you build it and they don't participate, they will not come, right? And so we have opportunity. I love your notion of it's not a technology problem. You know, the socio-technical model talks about this, right? That these days the technology is rarely the issue. Yes, there may be some cost, but it's much more than that. So let's go in reverse order here. Talk a little bit about the implementation centers and what we're doing, like the TEFCA use cases, the ECI. Without divulging, I know it hasn't been announced, the awardees, if you will, but talk a little bit about how many applicants, what kinds of things we're focusing on to try to modernize their abilities.
Yeah, no, I appreciate that. And I appreciate, based on my entire first rant, that CDC, Jim, your team, your office, a group of national partners realized you can't just expect public health agencies to read a blog and sign up for something, right? You need to provide them information and resources and funding. So the implementation centers are funded through the public health implementation grant programs to help modernize interoperability plus and workforce and other components. 68 agencies raised their hand and said, we would like to be engaged because we think it's important to do everything Michelle just said. Step back for a moment, think about all the individual siloed programs, all the separate data feeds, and really move into a modern framework where we can get only the data we need through the sources we need it from, work on it locally, work on it at the state level, and pass it to the CDC in a timely basis, hopefully without the faxes and envelopes. And so we're particularly eager to get started because the things we do in this room in interoperability around patient matching and secure data at rest and in transit and driving APIs to get the right piece of data in the right spot is exactly what public health needs. I'm just not sure they quite understood the language, and I don't think we quite understood their language back to make sure they were asking for the right things.
So for those who are unaware and aren't close to it, the 10th Amendment of the Constitution, you didn't think the Constitution would come up today, did you?
Bryant.
Give the authority for public health is at the states, not the federal government. So the CDC provides funding, guidance, can get the identified data and find trends across state lines for what's happening. But most of the responsibility for the delivery of public health resides in each state who has their own set of rules, right? And so, 50 states, local jurisdictions, right? Many states have home rule. Where local, same thing in the state where local has the authority more than the state, plus territories and tribes, right? So there's a lot of complexity there. And as we turn, so just so you all know, that's the setting. And APHL has done some interesting things with how do you deal with each state has a different list of what is a reportable condition. How do you support that as a national intermediary when you have 50 plus different rule sets?
Well, I do a lot of yoga and I do a lot of deep breathing, maybe some wine. So, number one, I think it's patience, right? At this point, it's patience because we do need to stop talking about use cases, right? There's this trickle-down effect in public health. You need your infrastructure, right? Just those secure pipes, and Craig and I talk all the time about these secure pipes. There's secure pipes for healthcare, but then there's the secure pipes that are almost like a preparedness level. You don't care data, you don't care if it's fire, you just need to get it there. And it gets thrown on an S3 bucket somewhere and people can look at their data, right? It's not pretty, but it works. Then you've got the brain, and the brain is trying to figure out how to distribute the data that's coming in from healthcare. Here's Washington State, here are the public health authorities within that state, what it means, and how we have to trigger it to move that data where it needs to go without, putting APHL in with liability, right? Because there's a lot of PHI. So most of the data that we deal with is data in motion, right? Craig is the one dealing with data at rest. And so there's different abstractions that really have to be understood. Because if we need to build infrastructure at the state and local level for everything that we're doing, we will never get there. And so what we're trying to do is to say, what are those things that the stilts and others need to be worried about, and what are those things that they don't, right? And how do we kind of centralize some of the expertise, the tools, and the services to actually help connect a decentralized system, right, based on where you live. So what we're trying to do is to, I don't know what our stats are right now. I think we're handling about 30 million, we're processing and handling 30 million transactions right now a month, right? It doesn't sound like a lot when you're thinking writ large, but, looking at the data itself and the value of that data at different levels of public health, I think is where the impact comes from, right? You guys are already contributing so much to what we have to do for public health. And I'll just end by saying, and it's because of people like Craig and J. Michael Consulting. I've been working with them since 2006, right? I've been working with Craig here just since last year, but I love them both equally, right? And there's all these new friends. I've got Mickey, who would just say, come meet me at a restaurant. Let me go buy you a cup of coffee, and I'm gonna tell you why public health has to be on TEFCA, right? It's people who are actually pushing public health in the right direction. And I think that the pressure to do so is allowing us to kind of push the barriers a little bit, right? And that's why I even brought Jay up here. Jay Nakashima from eHealth Exchange, he brought us to the table. He said, let's not duplicate efforts. Let's see how we can all work together to get, all of the jurisdictions that are already receiving ECR onto the TEFCA connection, and we did it. We did it without having to sign anything at the state level because of how we operate as a public health authority for the states. So I think there's a lot of investigation still to be done around what a public health intermediary is and how it fits into the bigger picture. But I think we're all excited to figure out where it will go, and hopefully it will be, right now I am sitting here as a steward for public health. We are stewards of the infrastructure. It belongs to public health, and it should be governed as such.
Yeah, to me, I find it really fascinating because I was in healthcare until about 15 months ago when I came over to CDC, and that national, the combination of working with, it's beautiful to watch, working with all the EMRs, figuring out how to develop that sniffer, right, of conditions. eHealth Exchange being the pipes. APHL being a self-serve, each state can go in and figure out which are reportable conditions for them. So the hospitals are reporting and clinics are reporting all the conditions, goes through eHealth Exchange. APHL does the rule set that says Louisiana versus state of Washington, they can apply their own rule set, and then it ends up at the public health department, the case investigator, all automatically, right? And then when they get that case report, with the example he was given is then, can we use the CRISP viewer, for example, on top of TEFCA to do the query for more info instead of I need more info.
Yep.
That's live. The providers just have to flip it on in their EHR. It's not required yet. Once we do it, it's going to be a different world. Let's come back to the local here. I think, how do you, the exchange purposes that exist today, and how do you see that evolving?
Well, I think, and I want to respond a little to Craig's comment of, like public health doesn't need to know TEFCA or shouldn't have to. We're partners in this journey. We've been told that this is an opportunity to really foundationally change how you operate. It's going to improve your speed, your ability to respond, your ability to get people what they need when they need it without overburdening your very, very limited workforce. So we're 100, and I speak for all my colleagues in the public health space, we're very invested, but we're a very small body of people. And helping recognize that we don't necessarily understand many of these things that have been discussed just this morning alone. As the conversations around treatment were fascinating. What constitutes treatment? We look at it and go, did this person receive the antibiotic that they need for that condition? And if not, we need to make sure that the attending clinician or our own public health physicians know that and can take the appropriate action. It really is so game-changing right now. And I think one of the challenges as I look at it from this lens is that everyone does want to say use cases. There's a use case for this and a use case for that and a use case for the other thing. But at the end of the day, most of these use cases are all equating to the same foundational capability. Getting access to data as appropriate now. I look at most of the work through the infectious disease side of the house. Public health is really growing and expanding. We're seeing where every jurisdiction has newborn screening. That's just the testing. Does an infant have a congenital condition that we should log somewhere? We're now pivoting towards doing longitudinal follow-up with these kiddos. And we need to gather that information. Are they seeing clinicians? What's the treatment for all that being? And today, it is literally, hi, I need some information. And they're chasing these kiddos across. It's not a fair statement to say these kids see lots and lots of different providers. Typically, they go to very specialized centers. However, people move. They're going to see other clinicians, and just understanding what's happened in this kiddo's life. This framework facilitates a much more streamlined approach to ensuring that we know where these children are in their course of their treatment, their life, and our public health assurance that they're receiving the needs, the assistance that they need.
Well, I think I want to leave a little time for questions, but I just want to kind of wrap us up before we get questions by bringing it back in. You're hearing about phone calls, I need more information. It sounds very transactionally administrated. But remember, it's about information about that tuberculosis patient so they don't give it to 5 people.
Yep.
Or go on one drug and we have multi-drug resistant tuberculosis that affects 10 of your family members, right? That's the kind of stuff we're talking about, why it's so important. And we got to go from the piecemeal to the reusable infrastructure and applications. That's the direction we're trying to head, but it is hurting a lot of cats. Hurting, not hurting, a lot of cats. So I don't know if there's a microphone wanderer, a Phil Donahue in the crowd. And if we're not set up for this, my apology for the showrunners. There we go. Questions, comments, words of praise for the panel?
Maybe
I think you're all on mute.
Yeah, while we're waiting, it might be worth really doubling down on what Tim said. The fact that public health is at the table at all,
Yeah.
I think it is a really important statement, both on behalf of public health and on behalf of Sequoia, eHealth Exchange, TEFCA Framework, the ASTP partners. There's still going to be a lot of work because, as you mentioned, Jim, the policies are local, jurisdictions are local, the regulations are local. Mm-hmm. So we've still got to go stilt by stilt, but we've done a lot of the hard work by getting this far.
Yeah, it's a team-based sport set up wonderfully by our ONC, ASTP coordination. We got tracks we can ride on. We're trying to get the locomotive going, right? We have a comment.
Jim, hi, Stephen Lane. So a lot of the conversations about public health exchange end up circling back to the challenge that CDA-based exchange doesn't quite meet the need. And we need to move, or we'd like to move as an industry towards fire-based exchange for public health use cases, and yet the people in public health, as we've heard repeatedly, are so busy or so tired or so underfunded that it's not going to happen anytime soon. How do we reconcile that?
Yeah. Well, I have a couple of things. Number one, I think that the question around CDA, it's quantity over quality, right? We talk about quality over quantity. CDA has everything. It's a clinical document, right? And I see but it has a lot. And so I think that the issue is that like I said, proof of concept, what was that ECR project, right? And what we're trying to do, at least on AIMS, and my ECR lead is here, and you can talk to him after, he's right there, you can yell at him. But what we're trying to do is to create a filtering mechanism that will support the needs of each program, right? Because we are not dealing, there's about 200, maybe 250 people in the world who really understands how to use the data that might come out of the CDA, and they're not gonna be working for $50,000 at a public health agency, I'm sorry. And that's another big issue that we could have a whole nother session on. But what we're dealing with here is how do we create that bridge, right? And if some of you were here, right before COVID, we were working with that organization called the Digital Bridge, where we were working with healthcare and we were trying to create the services and tools centrally that would allow public health to catch up and get the expertise. But the problem is finding all the expertise needed. And so, like I said, we're needing to figure out how to centralize some of that knowledge and figure out what we do with it so that we can shut off the secondary reporting and other.
Yeah, and just to add a quick comment from the CDC's perspective, there is a roadmap we've developed with our ONC partners to identify what, the challenge with fire is a couple-fold, right? One is educating people in public health about what it is. And milestone one is when they start spelling it with an H instead of, right? I mean, there's people that have no idea what we're talking about, right? And so there's a lot of funding. 4 times a year we bring in and pay for people to fly in to be trained by HL7 on 2-day training sessions to workforce development, right? So that's one piece of it. There's a roadmap for how we interact with our EHRA, our EHRs, how the Argonaut project is actually selecting things that will help public health from a fire use case. We have the accelerator, Helios, which is a public health accelerator to do connect-a-thons, et cetera. And then we have funded pilots. For example, I see Bryant over there in Washington. Several states have done pilots using fire to solve the local to state gap in data exchange. And then the implementation centers could be a nice landing place. So there's a strategy that's informed by the maturity of fire, by the adoption of fire. Both are different, right? And so there is a multi-year strategy. And I love the notion of a bridge because, there was some op-eds where Don Rucker and I think we're going back and forth. He said, we shouldn't be doing IHE, we should be doing fire. Well, people aren't there yet, right? And so I think it's a strategy over time to demystify the EICRs by processing them and teeing them up for the workflow while the world gets ready to finally replace it with fire one day.
And just to add, fire is a standard. It's not going to help data quality. So there still has to be those conversations around the data quality and the data completeness that can actually help public health do their job on the ground.
Yeah.
Which I think is important because fire is the next step, but it's not the only step.
Yeah. And I want to echo what's been said because public health does lag behind in our knowledge on capabilities with fire and newer technologies, but we're not naive by any means. And immense amounts of effort over the past 4 years at this point have really gone into socialization of this to the public health leadership, that this is an important thing that we have to get on the train. We can't stand on the side and wait for it to come to us. We actually have to be there, participants in the process. And Helios, as mentioned, watching the state, tribal, territorial, and locals participate in these connect-a-thons and these activities, we're starting to get critical mass within our own communities of people going, I need to know this. I'm going to come to the table. I'm going to learn more just through engaging with colleagues. So, yeah, we're not there. We're not at the same speed necessarily, but we're trying very, very hard to catch up quickly.
Well, thank you to everyone. I want to close by saying, just reminding us all, I think yesterday I said, economics professor of mine once said that the macroeconomic definition of technology is anything that improves the effectiveness or efficiency of a human. And healthcare is delivered by humans, right? And so the answer should be this: the table's set, and here's to one day public health workers not focusing on getting the data or preparing the data, but just focusing on the insights and the actions that the data turned into knowledge, turned into action. That's really what we're all about. And there's no better vehicle than information technology to get us to that place. And so thank you for all your collective efforts. There are many others that are not represented up here. It's definitely a team-based sport. It's even bigger than a soccer team, what it takes to get this done. So thank you to our esteemed panelists.
Thank you. Good job, darling.